Super. Perfect. Good. So let's start. So we live in a world that sadly has quite a few health inequities or inequities to access to healthcare. And with these, we mean that certain populations face and fear different access to appropriate health resources, diagnosis, prevention, and treatment. And I emphasize the and fear different access. So these inequities can happen through different mechanisms. It can happen, for example, due to geographic mechanisms. Imagine it's not the same to live close to a big hospital than very far from a health profession. It can happen due to economic mechanisms, having the capacity or not to afford the economic cost of a diagnosis or treatment for prevention. It can also happen due to cultural mechanisms. And an example here can be a language barrier, which as a patient poses a barrier to access the health system. But it can also, another example from the healthcare perspective would be limited awareness from the healthcare professionals about the daily life about certain conditions. There's also the big driver of health inequalities, which is a cultural barrier, which is discrimination. Discrimination is to worse diagnosis, worse care, and ultimately worse health outcomes. And we sadly live in a world with a lot of discrimination and a lot of implicit biases. So discrimination is happening under our babies, sometimes unintentionally, but ultimately harming everyone. And then the last mechanism would be evidence. So evidence hinders access to healthcare when different populations benefit differently from the level or quality of evidence. This happens if there is a skewed prioritization of what are topics of interest for research, and also if there is no good diversity and inclusion in the study population. So, knowing that, I want to go to the example of drug development, to a point can also feed development of health innovations in general. So this is a drug development pipeline, and most of the time, as we know, sadly, in pharmaceutical development, we've been based this development mainly on the male body. Historically failed to include females in clinical research, as has been shown, and therefore underserved this population. Now we know better, technically, we are trying, and we should know that we need to care about the sex chromosomes of our cells. We need to include male and female animals in the clinical research, and we have to embrace diversity and inclusion in our clinical research. And this goes beyond having males and females in our clinical trials and doing subgroup analysis by sex, which of course is a must, but we should go beyond and also make sure that we include also other underrepresented minority groups. These, for example, I think there was one person from the clinic, sometimes it's challenging because what to look for on how to define this population can be challenging, but should be done. And then when a medicinal product is developed, it goes into the real world. And here things become a bit more messy because here we live in a world in which societal mechanisms, power dynamics, behavior, biases, discrimination are going to influence who have access to these medicinal products or this innovation and benefits from it, right? So being aware of all these complexities is very important for health research overall. And now in the context of pharmacoepidemiology, this is to a point emerging right now. Pharmacoepidemiology studies the use and effects of drugs at the population level. So when we do also clinical trials, we use a lot of real world data. So it's data collected in routine clinical practice. And of course, this data basically reflects all the societal mechanisms, good or bad. And it's very difficult to see. So it's important to actively look for those. And that's how we came out with this framework. So among pharmacoepidemiologists, we partnered with health equity experts and community representatives to basically tell our community that beyond pharmacology, medicine, data analysis, and design, we needed to take care of societal mechanisms and health. So the goal really, and I think this translates to every health and research and innovation, is to improve the fairness of our research. So we know we need to improve diversity and inclusion in study populations and understand that we need discussions of what does diversity mean and how do we operationalize this. but also we target equal opportunity to healthcare. We want that everybody has an equal opportunity to healthcare and happiness. And ultimately, that whatever research we do bring us closer to health equity, so bring us closer to the absence of unfair, unavoidable differences in health among populations. Good. So we came out with this really messy thing, don't worry about it, but the important thing is, what is important? What is important? Why is it important? And how is that at the moment in European and real world data, and what's needed for it? So we're gonna focus for today in what is important, why, and then we will see how we can implement that. So these are all the diversity domains we are discussing. They are all determinants of health, either through biological or social mechanisms, and they are all intersect, though the concept of intersectionality that Jan already introduced. So that means that they all interplay with each other. I mean, you imagine an individual would fall in different groupings within all these dimensions, and that will shape the enablers and barriers that this individual will face in this path towards accessing healthcare. So let's start with sex and gender, very briefly, because Jan already told us a lot about that. So biological sex affects a lot of anatomical and physiological processes, such as, for example, body composition differences, with different allocation of adipose tissue, which is far more important beyond aesthetics, because the adipose tissue have a lot of influence in other aspects of our body. Sex also influences the immune system, especially between puberty and elderly or menopause. With the rule of thumb, females' immune system are a bit more aggressive. It also affects metabolism and body functions, such as gastrointestinal transit, the time that our stomach stays to release. And even how our bodies physiologically react to pain. So with all this and more differences in bodies, and most of this research is between females and males, because the research in intersex population is very, very limited. With all these changes between the female and the male body, then it's not surprising that we're also seeing different diseases. So like disease incidence, I think we have also seen that in Jan's examples. With autoimmune, Jan very well said that autoimmune diseases normally are more frequent in females because of the rule of thumb or aggressive immune system. And also difference in pathology and phenotype. So I give you the example of multiple sclerosis. This happens far more often in females, and yet males normally have a worse prognosis when they are diagnosed. So the disease incidence and the disease progression is different. And in here, even the sex hormones have been suggested as the reason for these sex differences in the progression of the disease. Then, of course, there are differences also in how our body absorbs, distributes, and excretes drugs. Although we take the same dose for everybody, this hopefully will change. And also examples of how some males and females respond differently to drugs. So this is just an example. It's vaccines. It's one drop per vaccine, different life phases, which is relevant for the immune system. And in purple, we see vaccines for which females have a higher immune response, and green a higher male response. So basically, this is just an example to keep in mind that this is seen also in other types of sickness and class, and ultimately we respond differently. Ignoring all this is a perfect example of an evidence mechanism for health equity. For health inequities. Now we go a bit more social. Gender, driven by social norms and stereotypes and the associated gender biases present in society, leads to changes in people's behaviors that can influence also health. An example of a behavior is prescription. So my prescription by healthcare professionals is done based on stereotypes and beliefs instead of facts, but instead of actually evidence-based, then one can do a lot of harm. And examples of these are, for example, seen in how pain is treated. And then the biggest, the big driver of health inequities, discrimination, which particularly or most in higher magnitude affects sex and gender minorities, not only because of bigger lack of evidence in their population, but also because of receiving direct discriminative attitudes in the healthcare system, and also barriers to access the care that they require. Good. So, sex and gender, big barriers, I would say evidence and culture. Good. Age is a well-known determinant of health. You will find it in almost every data you have. So here I'm just going to quickly highlight that it's nice to do research in adults. We shouldn't forget, kids, children, adolescents, important population here. And then with elderly, we know that there are body physiological changes, that there's mobility of disease, different treatments. And then what we shouldn't forget is that with elderly comes also psychological aspects that also can affect health and access to health, such as loss of purpose when a partner dies, or even social implications such as reduced income, which now intersects with socioeconomic status as another determinant. Merging sex, gender, and age, and also something that has been a bit shown before. I would like to go for the life stages. I'll tell you, life stages, well, among the work, we were sure this is definitely a determinant that needs to be in here. This is the most underserved. So with life phases or life stages, I mean phases in the life course of individuals that are characterized by strong swifts or changes in levels of sex hormones. Very briefly, sex hormones influence a lot of our different cells in our body. So they have a deep impact on the immune system, on brain health, on gut microbiome. So if you can imagine, when we have drops or ups of these hormones, makes sense. And of course, these phases are also sadly subject of social implications. So here I would like to highlight 3 phases, which are menstrual cycle, pregnancy, and so the menstrual cycle, sadly too much associated with taboos, has been very, very forgotten to the point that we have a hell of a lot of population suffering every month and thinking that's possible. So of course, this is changing. Now we know that if the pain affects you the other day, this is not good. And so there is emerging evidence of the interplay between the menstrual cycle phases in the absence of exogenous hormones, so the natural menstrual cycle phases, and fluctuating of disease symptoms in chronic disease. This is seen in rheumatoid arthritis, inflammatory bowel disease, lupus, and multiple sclerosis. The evidence is still small, more research is needed, but really this is telling us a lot. And then I'm currently working on also trying to push a bit more of the research on the interplay between the menstrual cycle and response to treatment. But there are examples of drugs that work better in certain phases of the disease, and also drugs that can have as an adverse drug reaction disturbances of the menstrual cycle. In pregnancy, I think we learned already a lot from Jan, so I will basically just only highlight that in terms of sex hormones, there are also changes in disease activity in immune-mediated diseases that are in pregnancy, but much more needs to be explored there. And pregnant women are still very underserved in the sense that, for pregnant females, we all get drugs independent. Well, sorry, we all get drugs. We all may need treatment at some point, and being pregnant doesn't mean you don't need it. And you would, as a pregnant woman or a pregnant person, you want that the treatment is, that you have certain level of evidence of what you're taking. So systematically excluding them from research is obviously not fair, and it's currently a lot of discussion. And then menopause, right now emerging, has its symptoms on its own, so obviously it deserves attention, and it also increases vulnerability for a lot of diseases. So these phases are very, very forgotten, and they should be really integrated as a very important factor in almost every health research. Good, how am I doing? Now it turns a bit to ethnicity. Okay. Ethnicity is a purely social factor, so until now it's a bit of a mix of biology and sociology and social holding hands. Now, purely social. Let me introduce what ethnicity is. Ethnicity is groups of people with shared attributes such as language, culture, social norms, roles, and behaviors. It's dynamic and it's very context dependent. From a data perspective, I like to say that we should consider ethnicity more as clusters than categories. We all belong to at least one, and we can belong to several. If you work in English, you may have seen that race often comes hand in hand with ethnicity. So race is groups of similar appearance. Some people have used race as biological variable. There's research that shows that can do a lot of harm, so please, social. In Europe particularly, I don't know in the rest of the world, the word race in many languages carries a lot of damage, has done a lot of harm. So when wanting to work with race, there's a lot of fear and a lot of barriers. However, we shouldn't let this fear stop the fact that race exists and racism exists, and we need to a point be able to identify, quantify, and address it. So my take-home message, so my tip here is, if race in your context is a fearful word, use ethnicity, but it's still, there is a lot of value in this determinant. And then just as a realization point, maybe a realization point on my side when we were doing this work was racialized groups. So our health experts told us, well, it's great that you want to implement ethnicity and race, but if you're looking for discrimination, sometimes racialized group is what we're looking for. This is third-party identified ethnicity, and it's particularly relevant when people migrate. Because maybe, let's put it this way, maybe in your country you had a slightly darker skin color than other people, and you would classify yourself, self-identify yourself in one ethnicity. And then you travel somewhere else, and people see you differently, and they put you in a different box, and you're going to feel the enables and barriers and access to healthcare based on that. So depending what you're looking for, sometimes you might need to ask people, what is your ethnicity, or where do you think people categorize you at? But anyway, just as a food for thought. How to operationalize ethnicity before I tell you why it's so relevant for health. Well, this is a very difficult thing that indeed can be worked out at many levels. We try to work this at the European level. We continue working this at the European level with the European Medicine Agency. There's no consistent grouping because it's so context dependent. So the take-home message is it has to be tailored to the context, the country, to the culture, and the groupings need to involve the community to be able to use the proper wording. Like, for example, in some places they use census and they do black and white women, and that would be unthinkable in other contexts when you would be more talking about Europeans of African descent and so on. So, if we look, for example, at which categories are used in European countries, some use geographical origin, migration. On the right, you see that sometimes instead of collecting ethnicity as such, they collect other variables that to a point are related, such as migration, nationality, language, religion. So a bit of a mix. And of course, they're all explaining different information and identify different groupings, but they're all relevant. So why is this relevant? Independently of the grouping, ethnic-based discrimination is widely spread. Let me give you an example of the Roma community. So the Roma community in Europe faces this direct discrimination where they access the healthcare system, and they have a massive gap in life expectancy compared to the general population. So a gap in life expectancy is a perfect example of, obviously, stronger barriers in access to health. With Roma women living in an average of 11 years less than women in the general population, and Roma men 9 years less than. If we think a bit outside the box of ethnicity, but close to it, migrants is also a very often researched group in Europe. So migrants face burdens to access to healthcare due to potential limited access due to legal status, especially, for example, depending on the reasons for migration. Being unfamiliar with the healthcare system, lacking resources like support system, with a limited system knowledge, if there can be anti-migrant sentiments, and then of course, if the migrant circumstances are difficult, there could be also trauma associated diseases. And all this is well documented, and all this increases inequities when also intersects with poor socioeconomic status and isolation, and also sadly affects depends. Good. Socioeconomic status. Okay, there are many different ways to define socioeconomic status, especially if you work with data, you will see that there's really a lot of differences. Important is wherever it's important to understand what you're really looking at. But ultimately, it's good because the economic barriers to access to healthcare are, pretty straightforward. Socioeconomic status definitions generally combine financial resources, income, educational level, health literacy, occupation, and social benefits. So why is this relevant? Well, let's look at some of them. Let's look at education, which is one of these aspects of socioeconomic status. There's a big gap in life expectancy depending on your educational level. And this is seen in several European countries, and then on the right hand some US data. We see also a gap in mortality in France, apparently, for different occupations. I'm using the terminology that they use in the paper or in the reports, but this terminology for occupation is not the best. Okay. For health literacy, which as you can imagine is super relevant for self-advocates, which is super relevant to navigate the healthcare system. And in Europe, there is more people with low health literacy among the population that is with financial deprivation, so low socioeconomic status. And then since a lot of health innovation nowadays involves digital aspects, I think it's important to also note that the level of education is also linked to the digital skills. So with health digitalizing, if you are doing anything like that, please make sure that if you're recruiting for your studies, you're recruiting also people with low levels of education, so you can tailor the innovation process for them. Good. And then the last one. The last one, health. Health status, disabilities, capabilities, different capabilities. So in many studies, in a lot of research, actually people with very active disease, physical or cognitive restriction are often excluded, sometimes unintentionally. Sometimes simply they couldn't make it to wherever the study facility was. So by this exclusion, ultimately a lot of these innovations have not been developed for people who may need them the most. So a call for action here also research, make sure that you're targeting also people with certain physical or cognitive disabilities. Good. So after this whole roller coaster of things that we should watch out for, diversity, domain, determinants of health, all intersected, all affected access to healthcare through different mechanisms and therefore driving inequities. How can we move forward with this knowledge? So let's do something. So this is when I present the framework. The framework is explore, tailor, implement, and evaluate. So let's start with explore. So very early on, this is mainly targeting researchers. So very early on in your research phase, you need to be curious, question and explore, and think what would be the role or the potential role that these different diversity domains or determinants of health could play in your research question. And you have to sometimes go a bit of an extra mile because often there will not be research on that. So think of rationale. Identify what could be relevant and tailor it to your context. So what I mean with tailor is something as simple as age. Is age relevant as a continuous variable, or is it you want to work with age categories, groupings? And if so, which ones based on what? Ethnicity, as I said before, which type of clustering or grouping is used in your context? Maybe look at the census. Maybe talk to the community. Even define it. Implement it. So, for example, if you're recruiting for a study, you're collecting. Make sure that you have a strategy to reach everybody you want to reach and not leave anybody out. And if you are when you're defining the eligibility criteria, so who's going to be in your study, make sure that if you're excluding someone, you have strong arguments for it, you describe them transparently, and you're aware of the consequences of that exclusion. As Jan mentioned, sex disaggregated analysis and health research are a must as a bare minimum. Very often is said, oh, but they're underpowered. So that means that the sample size, the size of the group will be too small to get statistical conclusions. Doesn't matter, just do it. Because even underpowered subgroup analysis are relevant. Even if results are taken with caution, ultimately is information, and then maybe a meta-analysis will come, combine many studies and have a more robust finding. And then, because before you explore the role of other domains, if some of those domains were also highly important, then do more subgroup. And evaluate. So even afterwards, check that you indeed gave the opportunity to everybody that you gave the opportunity to join the study, that diversity and inclusion was correct, and that the benefit that you expect that comes out from your research reaches everybody that should reach. So if you work with data and you're doing some kind of prediction model, for example, as an example, then check prediction standards, checks the performance of your model in different populations. Easy. Good. And then, once we've done all that, of course, we have to communicate the results. And these domains, as you may have noticed, they are very sensitive. Some more than others, but they can be very sensitive. So communicating results that are in direct relationship with these domains need to be done with caution. Especially if there is any chance of misinterpretation that could give a hint of different populations maybe having different capabilities or different rights. Let me give you an example here. There is a lot of harm done in medicine when they said that women had a smaller brain, blah, blah, blah. Now we know that our female brain and male female, indeed, for certain things, work differently. And this is not necessarily meaning that one brain is better than another. It just means that, we're learning more now about the female brain and we can implement this knowledge and have better care for everyone. But if this is not communicated properly, it can do kind of harm by those who don't get the message. So this is just an example. And then if you wanted to do great research and you were using data that already existed and didn't have the right variables, the right information, mention it in when you talk about your research. Mention, I wish I would have been able to incorporate ethnicity, but I didn't have it. And I mentioned here that I would like to have it, and if I would have it, I would have that, this and that with that, and I would have benefit, the study would have benefit in this and this way. Good. So, action points: be innovative, explore, discuss, work in interdisciplinary teams, involve the community, and advocate. And then for those who are not researchers, if you hold data, then please enlarge data availability of these determinants. If you work in policy or regulatory, you have a strong voice, so say it loud. If you're a clinician, with clinicians, I didn't go much into detail today, but I think Jan did a lot, so be curious and question your own biases. Citizens, spread the word. And educators, if you see any way you can implement this in your talks, this goes on. Yeah, thank you very much. Any questions? No? Thank you very much for the great and very clear talk. I was wondering how it is in pharmacology nowadays if they test a drug. Do they
would it analyze better all these factors?
So, okay, in Europe, they need to do subgroup analysis for sex, age, and a few others. They do not need to do absolutely anything with that afterwards. So there are indeed examples, for example, the new promising 2 Alzheimer's drugs in the pipeline. If you look at the subgroup analysis, the effect on females is less clear. I'm not saying it's not there, I'm saying it's not visible with these subgroups. So at the moment in Europe, this is not yet enough. There's a lot of discussions for sex of whether they should do at least, be more fair. I think it's gonna take a while. But I see a lot of power in society claiming this, and also clinicians. I mean, you need to treat your Alzheimer's patients with these treatments. Although they work in the overall population, if there's a group analysis that shows no effects in females, I think you're entitled to come to the company and say, hey, run a bigger studies in females. Now, in terms of other underrepresented groups, the discussion was much bigger in the US before Trump. And the FDA, the Food and Drug Administration of the medicine agencies in the US, they were actually requesting the same standards for trials done in Europe. So then the pharmaceutical companies in Europe were actually getting super active to see, how do I measure ethnicity here? Because of course, Latin American and African American doesn't really fit. Now here we have, if anything, African, Europeans of African descendants, and whatever. So the grouping didn't work. And there was movement happening. And then the world changed it. And US stopped that, went backwards, and Europe said, okay, fine. So at the moment, yeah. But for example, as I said, this framework triggered this health equity group within the pharmacoepidemiology MSEP group in the European Medicine Agency. So we are moving slowly. For clinical trials, which is the most regulated phase of research. For the rest is not regulation. Does that answer your question? Okay.
Thanks for going forward with this topic. My questions? Also going into the topic of clinical trials, in which way is it actually compulsory to include now sex and gender disaggregated culture data?
So the subgroup analysis, disaggregated data, that needs to be done.
So it's not mandatory.
No, it is mandatory.
It is.
What is not mandatory is to do something about it. So, okay, so let me put it this way. When you do let's say you have your main outcome and your expected effect and your variability within the effect, and you want this to be statistically significant. So with the subgroup analysis, you may or may not see different groups. At the moment, there are flags in the market that when you look at the subgroup analysis, in some of the groups, there's no visible effect. So basically, the variability is covering the one, no statistics. It depends on the regulators. They need to read this information, and if they consider that something else needs to be done, then they request it. So at the moment, to my understanding, this is not yet often happening unless it's very traumatic. Because not seeing an effect in a subgroup analysis could be simply justified as this underpowered. That's why a lot of this work goes for regulators, because it's really up to them to say, even something like, look, fine, we go further with the approval, but you need to do a post-marketing study in this population. And if they do that, then companies need to do it. And that's a really nice way forward that doesn't hinder innovation, but companies do it.
just a question to that. Would it not be the best? Oh, thank you. Would it not be the best to just have an approval female or female drug and male drug?
So not for every drug, if that's important. So in an ideal world, in a phase 1 trial, when you're looking at pharmacokinetics, so how the drugs is absorbed, distributed, and excreted, which is normally where most of the sex difference are seen, or at least you would expect. If in there you already see differences, you could do subgroup analysis, you could do interaction analysis and see whether this difference is significantly relevant to continue moving with it. It would be good to then continue separately or not. Not for every drug is expected that it will be needed. So I wouldn't necessarily say do things for females and males separately. Also because we're going for personalized care. So now it's females and males, but it could be that there are other aspects that are also relevant. It could be age. We need to be a bit more open-minded and think, I want to explore different groups. I want to see if it makes sense to go separately for each group. And they may need different doses, different drugs, different. That's not.
Yeah, I understand.
Yeah. It's difficult because it adds hell of a lot of economic burden. So doing a clinical trial in males and females, you could say it takes the double money. If you want to do it in a way that you can indeed check afterwards and compare one with the other, then it's even more than double. So you can imagine that the industry is not going to do it until the regulators request.
Yeah, I see. Yeah.
Thank you. Hello, nice to meet you guys. We're designers at Systematically, and so I'm not very familiar with clinical trials. I was wondering if do pharmaceutical companies have to disclose whether or not they've done subgroup analysis to consumers, to patients?
That's a good question. Okay, so when you run a clinical trial, you need to register for a new drug. You need to register your trial publicly. So there's actually a public registry that you can see. And then when you have results, you have to put them there. I'm not sure at the moment how much of the subgroup analysis is mandatory to be shown there. And then not every trial is published in terms of publications, but there are quite a lot of scientific publications which in the supplementary material have the subgroup analysis.
Okay, I see.
So that's why we know that indeed it makes a difference, but there's much more than we see.
Right. Okay. Thanks. Thank you so much.
Any question? I would have one.
Yeah.
Was there anything that you had to follow or to not include, did not include the test? Right.
Oh, like a lot. No, I mean, initially our timer was not going to be very different. I mean, we are basically data-oriented people. We wanted categories. We did not envision a framework that was going to guide people's thinking. We envisioned something that says, this is how you measure ethnicity, this is how you deal with age, and this is how, and then it was like impossible. So we had to throw a lot overboard. A lot. And then just think the whole idea.
Could you name some factors that you want to?
Like, for example, it was very difficult not being able to say this is groupings. We really try to have even like, I mean, there are a few groups that, at least in the European Union, are commonly used and researched, like, like migrants, Roma, there's the family, there's the African descent, European Muslims, again, religion plays a game too, it's religion, geographic origin, everything. But then when we were discussing and translating these things to the different languages, that was a mess because a lot of things were like, no way I could say this here. So that will throw overboard. We are not giving categories. But we are trying to build on that now within this a different group that is more at the European Union level. And again, everybody expects us to come up with categories, and I don't think it's gonna happen. Yeah. This is something we gave. Yeah, we initially did not think to even have to go through the explanation of all the diversity domains. We thought it was obvious. And then we realized that it's definitely not obvious. A lot of people are like, oh yeah, there's discrimination, but that doesn't affect treatment response. They're like, well, yeah, but if there's discrimination and they're not offered tests in the clinic and they get a late diagnosis, or that someone cannot afford a treatment, surely this let alone affects also treatment response. And when we study and compare two drugs, when you took that drug makes, and you know what you carry on before makes such a big difference. So yeah. So
Fantastic. Thank you so much, Enriqueta.